A good evening, a very good evening to all of, and a warm welcome to all of you. On behalf of Heartlines, the voices of cardiac anesthesiologists, I am truly delighted to host you for our episode 10 of our series. Today, we turn our attention to a condition that is both dramatic and unforgiving, the acute aortic dissection, a race against time. This is one of the most feared emergencies in cardiovascular medicine, where every minute counts. So, a tear in the aortic wall is not just a surgical challenge, but a true multidisciplinary test, demanding the vigilance of physicians, the precision of surgeons, and the resilience of cardiac anesthesiologists and the critical care teams. In this session, we will explore how to recognize the early warning signs, to streamline the diagnostic pathways, and orchestrate the perioperative management that can mean the differences between the life and death. So we'll hear the perspective that combine the clinical wisdom with the cutting edge practice, and we hope to create a discussion that will sharpen our readiness for this most urgent emergencies, sort of an urgent of the all emergencies. So I invite you all to engage actively, share your thoughts, and let us together learn how the race against time with knowledge as our greatest ally. So welcome once again to the Heartlines episode 10. Let's begin our journey to the world of acute aortic dissection with Dr. Soumitra. He is one of the very good speakers I have ever known. Dr. Soumitra, up to you. He is head of the department cardiac anesthesia and in charge of OT. And Dr. Soumitra, please continue.
Okay, thank you so much, Shomiri. The introduction part, which I was supposed to speak, you have covered a lot and in a very good manner. So, after this introduction about the aortic dissection, why it is so much important for the surgeon as well as for the anesthesiologist, this has been covered by Mukherjee. Let's begin with the management of the aortic dissection, starting from the definition to the post-operative management as well as the strategy for rehabilitation and follow-up. I will cover in a nutshell. The time constraint is a factor here. So I have tried to cover almost all domains or the segments of management of aortic dissection. Few points, although will not be covered in detail, like deep hypothalamic circulatory arrest, which itself will take almost 1 hour to discuss. The rest of the part I will try to cover. Definitely, if you have any query or any suggestion, we can discuss once my presentation is over. To start with the definition of aortic dissection is an event of sudden onset in which blood leaves the normal aortic lumen through a usually discrete point of exit, which is considered as an intimal tear, and rapidly dissects in order to form the outer layers of the tunica media of the arterial wall to produce a false lumen. Now, once this false lumen has been developed, the site of intimal tear as well as the extent of false lumen, it may be localized at the primary entry site, at the origin intimal tear, or it may extend proximally towards the heart or distally towards the periphery, or it can be extended both proximally and distally. According to the duration of the aortic dissection, it can be classified into three types. Number one, acute. When the dissection has been occurred within 14 days of presentation to you, it is acute aortic dissection. If the incidence happens in between 15 to 90 days, it is considered as subacute dissection. And if the dissection lasts more than 91 days, then it is considered as a chronic aortic dissection. Coming to the Ishimaru zone, previously what we have been taught about the location of the entire aorta, that is the ascending aorta, the thoracic aorta, as well as the abdominal aorta. Ishimaru has changed the nomenclature of the aorta dramatically, and now it is being advised or suggested to identify the type of the aortic dissection and to report the type of that aortic dissection according to the Ishimaru zone. Now, Ishimaru has subdivided the entire aorta into 12 segments from 0 to 11. This is the pictorial depiction of how the Ishimaru zone actually subdivides the entire aorta, starting from the aortic annulus to the femoral artery. Next is the Gerarda score. For the other type of the aortic surgeries, apart from other types of cardiac surgeries, particularly the adult cardiac surgery, apart from the aortic surgery, we used to signify the perioperative risk of mortality by two ways. Number one, either through calculation of the STS score or through calculation of the Euroscore 2, which is randomly used worldwide. Even I also use it. But for the aortic surgery, neither the STS score nor the Euroscore, Euro 2 score is applicable. Here, the another score is applicable. It is called Gerarda score. The full form is German Registry of Acute Aortic Dissection Type A. It is the class 2A recommendation to calculate the Gerarda score and accordingly to stratify, to signify the perioperative risk of 30-day mortality after the surgery. The components of Gerarda score are like age, sex, resuscitation before surgery, whether previous cardiac surgery has been done or not, whether the patient has been presented to you on ventilation or not, whether already patient is on any anaerobic support, whether aortic regurgitation is present or not, preoperative hemiparesis in the form of end organ ischemia is present or not, or any type of extension of the dissection, it has to be counted. And lastly, the location of the primary entry tier within the aortic arch has to be counted. Now, according to this score, if the score is calculated as less than 15%, the risk is of lower category. If the score is calculated between 15 to 30%, the 30-day mortality after the surgery is considered as moderate. If the score crosses more than 30%, it is a severe category. Coming back to the classification, we all know from our initial MBBS days the classification of aortic dissection, the very famous D. Becket classification. Even D. Becket is one of the founder of aortic surgery, particularly for the aortic aneurysm. He did the first successful aortic surgery in the year 1955. So he has contributed a major contribution for the aortic surgery. So according to the D. Becket classification, type 1 is the type where the intimal tier usually originates in the proximal ascending aorta, and the dissection involves either ascending aorta, arch, or the variable length of descending thoracic or the abdominal aorta. Type 2 is the dissection is confined within the ascending aorta only, no extension. Type 3 is dissection may be confined to the descending thoracic aorta, or it may extend into the abdominal aorta or the iliac arteries. This is the diagram of D-Beck classification of the aortic dissection. Another very common and very lucid classification is Stanford classification. According to the Stanford classification, aortic dissection is of two types. Type A is where all the aortic dissection cases in which the ascending aorta is involved by dissection, with or without involvement of the arch and the descending thoracic aorta. Type B is where only descending thoracic aorta is involved. However, occasionally the dissection, although it is originating within the descending thoracic aorta, it may extend proximally to the aortic arch, but not to the ascending aorta. Whenever the ascending aorta is involved, it is considered as type A. This is again the diagram of type A and type B Stanford classification of aortic dissection. Coming to the newer classification of aortic dissection, it is a very new addition of the classification of aortic dissection, because it has been seen that considering the D-Beck and or the Stanford classification, sometimes it is difficult to type B. According to this classification, there exists another classification which is not type A or not type B, that is non-A, non-B aortic dissection. The details I am coming later. The E stands for location of the entry point, that is the intimal tear point. E0 equals to no entry is detectable according to our the investigation procedures. E1 is the entry point is present within the ascending aorta. E2 is the entry point within the aortic arch, and E3 is where the entry point is within the descending aorta. M stands for malperfusion. M0 is there is no malperfusion. M1 is because of this dissection, the coronaries have been involved. M2 is supraortic branches, not the coronary, but the branch vessels have been involved within the pathology. And M3 is the distal vessels, the peripheral vessels like spinal artery or visceral artery, renal or iliac arteries have been involved within the pathology because of this aortic dissection. So this is the classification of aortic dissection according to the TAME classification. Now, what is non-A and non-B type of aortic dissection? We all know that in type A, it is ascending aorta, type B, it is descending thoracic aorta, sometimes involving aortic arch. But sometimes it may be happen the dissection point is within the aortic arch itself. Wherever there is involvement of the aortic arch, I mean the entry point is within the aortic arch, but it has spared the ascending aorta, it may extend into the descending aorta, but it has to be spared the ascending aorta. It will be considered as non-A, non-B. Why the sparing of ascending aorta? Because again, if the ascending aorta is getting involved, it is considered as a type A. What are the risk factors of aortic dissection? Cystic medial necrosis of the arterial wall, Marfan syndrome, some other syndromes like Turner syndrome, Noonan syndrome, Ehlers-Danlos syndrome, etc. Annuloectasia of the arterial wall, bicuspid aortic valve, very close proximity, close correlation with the aortic aneurysm and the dilated aorta and the dissection of aorta. Again, dilated ascending aorta, Some iatrogenic cause like aortic cannulation or clamping of the aorta, closed chest trauma, intramural hematoma, and lastly, uncontrolled systemic arterial hypertension. Pathophysiology in a very brief manner. What happens in aortic dissection? Now, the aortic wall has three layers. You all know the intima, tunica media, and tunica adventitia. Chronic exposure to high pulsatile pressure and shear stress, especially in susceptible individuals, means the individuals who are already having the risk factors, their arterial walls already in a state of weak state. Now, this continuous pulsatile pressure, high pulsatile pressure and shear stress, it leads to intimal tear formation, which is an initial event. Aortic dissection occurs when that tear in the intimal layer of the aortic wall allows blood to enter within the space between the intima and media. The blood, which was initially present within the intimal layer, within the aortic lumen, now is accumulating in a layer between intima and the media. That will create a false lumen. Now the blood continuously is getting accumulated within that false lumen. That will ultimately lead to expansion of that false lumen. As the false lumen develops, it typically becomes larger than the true lumen because blood is continuously accumulating within that false lumen. That once that false lumen becomes so larger, in comparison to the true lumen, it increases the risk of aneurysm formation as well as eventual rupture. So that is the pathophysiology of acute aortic dissection in a nutshell. What are the complications we can expect from aortic dissection? If the aortic dissection extends proximally towards the heart, it may cause cardiac tamponade, which is life-threatening. The aortic regurgitation in the form of either mild, moderate, or severe variety. If the dissection involves the coronaries, it may cause myocardial infarction. If it involves the branch vessels, it may cause stroke or paraplegia. If it extends more distally, it may cause limb ischemia or mesenteric ischemia. Now, what are the clinical features of aortic dissection? The most feared clinical feature is sudden death. Many a times, the patient presented with acute aortic dissection doesn't have enough time to come to the hospital, to come to the doctor. So, sudden death is one of the commonest presentation for acute aortic dissection. Apart from the sudden death, what could be the feature like sudden severe pain? Now, many a times, severe chest pain because of aortic dissection mimics the acute coronary syndrome. The chest pain, type of chest pain or category of chest pain is very similar to acute myocardial infarction or heart attack. The chest pain, it is mostly precordial or it may be interscapular that radiate towards the jaw or the arm. Very close, very similar to presentation with MI. Many a times it is sometimes difficult to differentiate from the clinical features or the according to the characteristics of the pain between the AMI and the acute aortic dissection. If the dissection has involved the peripheral arteries, the peripheries may become numb, pale, or pulseless. The involvement of the arch vessel may present with stroke or paraplegia. If the renal arteries are being involved, there may be oliguria or anuria because of acute kidney injury. So these are the clinical features of acute aortic dissection. These stroke, paraplegia, oliguria, anuria, these all actually signify the malperfusion of the peripheral arteries. So coming to the management proper of aortic dissection, whenever a patient comes for aortic dissection, obviously it is a medical emergency as well as a surgical emergency. Prior to the surgery, we have to do our routine preoperative investigation, the arrangement of blood and blood products. By that time, we have to optimize the patient also for the surgery itself. Now, while we are optimizing the patient in the preoperative period, the important strategy or the most valuable strategy is that two things. Number one, strict blood pressure management, and number two, control of the pain. Pain is so severe that it may eventually accelerate the rupture of the, accelerate the further rupture or the extension of the tear of the aortic dissection. So control of the pain is of utmost importance by any means. Coming to the control of blood pressure, prior to the control of blood pressure, first of all, class session.
Yeah, Dr. Soumitra, we are getting your voice cracked. Oh, Dr. Soumitra? I think he has got disconnected. Yeah, he's coming back.
Hello.
Yes, your screen is just starting now.
Let me share my screen.
Yeah.
Is it visible now?
Yeah, visible.
Okay, sorry, I have to take an urgent call from ICU.
It's okay. Okay, it's okay.
Okay, so I was talking about the
Blood pressure management. Yeah.
yes, I know. The initial medical management in the form of strict blood pressure management and control of the heart rate. So prior to the control of the blood pressure, you have to control the heart rate. For the control of heart rate, the drug of choice is beta blocker. We usually use the esmolol, initial bolus of 5 to 25 milligram intravenous, followed by a continuous infusion of 25 to 300 up to 300 microgram per kg per minute. The targeted heart rate is between 60 to 80 beats per minute. Now, those patients who are where the beta blocker is contraindicated, we have to use the either diltiazem or verapamil. But first of all, apart from control of pain, we have to control the heart rate. Once the heart rate is within the suitable range or desired range between 60 to 80, if still the blood pressure is on the higher side, we have to use the vasodilator, either nitroglycerin or nitroprusside. The target systolic blood pressure is 100 to 120 millimeter of mercury. While we are managing the patient in the ICU for optimization, usually the invasive monitoring within the ICU is preferable in the form of invasive arterial pressure monitoring line as well as central venous line. So while we are optimizing the patient in the ICU, at the same time, simultaneously, we have to go for the diagnosis proper. Once the patient comes in the emergency, the only one blood test, if you want to send, is the D-dimer. If D-dimer is negative, it means mostly this is not aortic dissection. But if the D-dimer is raised, there is a doubt or suspicion of having aortic dissection. Apart from D-dimer, the chest X-ray findings are: number one, there will be widening of mediastinal shadow, either because of aortic regurgitation or the cardiac tamponade. There could be again cardiomegaly. There could be pleural effusion also, mostly on the left side, but sometimes bilateral effusion can be seen because of pulmonary edema or left ventricular failure. Next, very important and very much of diagnostic value is the computed tomography or the CT scan. ECG trigger or the fast acquisition technique CT scan is preferred to diagnose acute aortic dissection. While we are locating the entry point or the flap within the aorta for the diagnosis of aortic dissection, at the same time, we have to detect whether there is any concomitant coronary artery involvement is present or not. Also, concomitant branch vessel, whether the aortic arch involvement is present or not. There are two phases of CT scan. The contrast enhanced arterial phase, if it is extending from the thoracic inlet to the level of the femoral artery, that will give you an overview of the entire aorta, the location of the tear, as well as the extension of the aortic dissection. Whether the venous phase series of the CT scan in the form of CT angiography, it is helpful in the post-operative period, particularly to know the existing of the false lumen even after the surgery, or if there is any endoleak after the TAVR implantation. While we are doing the CT scan, the CT angiography is also helpful to know the patency of the circle of Willis. Why it is important? Because if you are planning for either hemi-arch or complete arch replacement, to know the patency or the morphology of the circle of Willis is of utmost importance. This is the diagram of CT scan of thorax. You can easily locate the how the aortic dissection looks in the CT scan, because in the examination, the examiner may give you the plate of the CT scan only and to ask you about the diagnosis. From Dr. Ravi, am I audible and visible?
Yes,
Hello?
you are audible.
Okay. Okay.
Visible too. Yes.
Okay.
Continue, please.
Okay.
He was explaining that CT scan.
Next is the MRI. For the aortic dissection, MRI is rarely used because the CT scan itself is a very good investigating tool to diagnose accurately everything about the aortic dissection. But sometimes MRI is also helpful where in a situation you want to know whether you want to assess the ventricular and the valvular function, particularly in case of severe aortic regurgitation. In these situations, the MRI could be helpful. Transthoracic echocardiography, it is helpful or rather useful for visualizing the aortic root, the ascending aorta, as well as for assessing the anatomy and function of the aortic valve, whether aortic regurgitation is present or not. Also, it will be helpful to know the complications like left ventricular dysfunction and the cardiac tamponade. In the emergency, the first investigation which we do in a suspected aortic dissection is the transthoracic echocardiography. Transesophageal echocardiography, it is better than transthoracic one, but sometimes it is difficult to do when the patient is not intubated because it is an invasive procedure, so it will cause stress and pain for the patient. But once the patient is intubated in the ICU because of either hemodynamic instability or because of low GCS, because of stroke, then you can easily perform the TE. Definitely, TE is very much helpful, very much informative in comparison to the TTE. TE is also helpful in a situation where the because of hemodynamic instability, you cannot transfer the patient to the CT scan room. And also, TE is also helpful in the operation theater to guide the surgeon about the plan of surgery as well as for the TEVR procedure. Now, one of the commonest complication of aortic dissection is aortic regurgitation. Many a times we have seen that starting from the mild variety up to severe variety, there is associated aortic regurgitation along with the aortic dissection. Presence of aortic regurgitation obviously changes the plan of surgical management. Now, aortic regurgitation, because of aortic dissection, it happens by 4 reasons. Number 1, type A is the circumferential even involvement of the entire root and the annulus of the aorta, causing central aortic regurgitation. But in type B, the involvement of the root or the annulus is not even; it is uneven, and the extent of intimal tear, rather the false lumen, it actually compresses one of the valve cast, causing the component of that valve cast to become flayed. That will cause eccentric aortic regurgitation. In type C, there will be so much involvement of the aortic dissection that in an extent it will involve the aortic cast also. So that will again cause your eccentric aortic regurgitation. In type B, what sometimes happens is that the flap itself impinges within the opening of the valve cast. So there will be difficulty in proper coaptation of the cusp of the aortic valve. Again, it may present either as central or eccentric jet of aortic regurgitation. So these are the 4 types by which aortic regurgitation can be happened in a case of aortic dissection. Some guidelines about the measurement while we are doing our investigation. In a patient with known or suspected aortic disease, it is recommended the aortic diameter be measured at reproducible anatomical landmark. Means whenever you are assessing the aortic diameters, either at the root level or sinus level or intra-aortic sinus or ascending aorta level, it should be perpendicular to the axis of the blood flow. I mean, when you are measuring through echocardiography. When performing CT scan or MRI, one should consider measuring the aorta from the outer edge to the outer edge, not the inner edge, if the vessel wall is properly visible. One should consider also measuring the aortic root from sinus to sinus, means the intersinus distance is actually the measurement of the aortic root. And the largest diameter measured should be considered as a reference value for that particular patient. This is the transesophageal echocardiographic view. This is mid-esophageal aortic valve short axis view. You can see this is a bicuspid aortic valve pathology and hugely dilated aortic root as well as the aorta itself. This is mid-esophageal aortic valve long axis view. You can easily locate or identify the presence of flap. You can see the aorta is so much dilated that it has compressed the left atrium. The only thing which we can see here is the aorta. This is upper esophageal aortic arch long axis view. For the same patient, the extent of dissection has involved the aortic arch also. We did the
You are not audible, Dr. Soumitra.
mid-esophageal. Here, the hello, am I audible and visible?
Yes, now audible. Yes, continue, please.
Okay. Is my screen visible?
Yes, it is visible.
Thank you. So this is the ascending mid-esophageal ascending aorta short axis view. You can see the presence of false lumen and true lumen properly. Okay. So the larger one is actually the false lumen, and the smaller one is actually the true lumen. This is the mid-esophageal 5-chamber view. You can see the whole actually sector is being occupied by the dilated aorta, and you can locate the presence of dissection flap and presence of mild aortic regurgitation also. This is again presence of aortic flap for the same patient, mid-esophageal view. So this is about the transesophageal echocardiography, where you have to identify the presence of flap, the presence of false lumen, and the true lumen. Now, how could you differentiate between false lumen and true lumen? Generally, the size of the false lumen is bigger in comparison to the true lumen. Generally, there will be spontaneous echocontrast or the presence of thrombus within the false lumen. Generally, the flow within the true lumen happens in the systolic phase of the cardiac cycle, but the flow of blood within the false lumen, it happens in the diastole phase. So these are the and the fault line. Apart from these routine investigating tools, there are certain other investigating tools which are emerging within the field of investigation. Number one, automated measurement of aortic dimension. This actually helps us to avoid the inter-observer bias. Automatically, the software will measure the aortic dimension in a very, very accurate manner. So there will be no discrepancy what you have find in your diagnostic tool and what the surgeon will find after opening the aorta. Next is the 4D MRI. Again, it will be helpful for assessment, particularly of the aortic valve, the ventricular function, the volumetric measurement of the blood flow. Next is the photon counting computed tomography. Photon counting computed tomography. It is a cutting edge normal CT scan, and the picture quality, the precision, and the diagnostic accuracy is even better than the normal routine CT scan. Coming to the management proper, this is the flow chart of acute aortic dissection type A. What we will do according to the type of aortic dissection in case of type A aortic dissection. In case of TAME type A, E0, now you know what is the TAME classification and what is E0. E0 means you cannot locate the entry point. That is, entry point is not detectable. The surgical plan of management is emergency ascending aorta and the hemiarch replacement. In case of TAME type A E1, that is, the entry point is within the ascending aorta, the plan of management is emergency ascending aorta replacement and hemiarch replacement. In case of type 2, TAME type A type E2, that is, the entry point is within the aortic arch. If the entry is at the outer curvature, then emergency frozen elephant trunk guided surgery is required. But if the entry point is not at the outer curvature, again the plan of management is emergency ascending aorta replacement and hemiarch replacement. In case of type E3, if the entry point is within 10 centimeter distal to the left subclavian artery, then the again frozen elephant trunk is applied. But if the entry point is not within the 10 centimeter of left subclavian artery, in case of type E3, the plan of management is emergency ascending aorta and replacement and hemiarch replacement. In case of type non-A and non-B, where the entry point is itself within the aortic arch and there is no involvement of ascending aorta. Non-A, non-B type E0, then the management is optimized medical therapy and regular imaging follow-up. If the type is E2, if there is presence of high risk feature, what are the high risk feature? I will discuss later. If there is presence of high risk feature, you first start your optimization of the patient and urgent application of the frozen elephant trunk. Now, what are the criteria for urgent frozen elephant trunk application? Number one, if there is malperfusion of the presence of malperfusion of the spinal cord or GI ischemia or involvement of the kidneys, presence of pleural effusion, etc. These are the actually features of application of urgent FET, and it should be done within 48 hours. Now, if it is a presence of high risk feature as well as complication is there, in case of type E2, then you have to go for the emergency frozen elephant trunk immediately. You cannot wait even for 48 hours. Now coming to type E3. If there is no high risk feature, you optimize the medical therapy and keep the patient on regular follow-up with regular imaging. But if in type E3, complication is present, complication in the form of, I've already mentioned, involvement of peripheral arteries, involvement of there is pleural effusion because of heart failure, then you have to measure the diameter of the ascending aorta. If the diameter is less than 45 millimeter, then you identify whether the anatomy of the aorta is suitable for TAVR. Now, what is the meaning of the suitability of TAVR management? It is the length between the landing zone and the entry point. If it is more than 20 millimeter, it means that the anatomy is suitable. If the anatomy is suitable, then you go for TAVR management. But if the ascending aorta diameter is less than 45 millimeter, then you have to go for the emergency frozen elephant trunk application. Again, if the ascending aorta diameter is less than 45 millimeter and your anatomy is not suitable for TAVR, you have to go for the emergency frozen elephant trunk. Now, what are the criteria for high risk consideration? Consideration of the high risk category for type non-A and non-B. Number one, primary entry more than 10 millimeter. The length of the entry. Primary entry at the inner curvature. Primary entry located less than 20 millimeter in relation to the left subclavian artery. False lumen diameter more than 22 millimeter. Descending thoracic aortic diameter more than 40 millimeter. And high systolic antegrade flow volume in the false lumen with significant diastolic retrograde flow, which is assessed by MRI, which is actually rarely done. The clinical criteria are persistent pain and uncontrolled hypertension. So these are considered as high risk criteria when you are managing the non-A, non-B type of aortic dissection. Coming to the aortic dissection type B. Type B without high risk feature, the features I've already mentioned, the same features of type A and type non-A and non-B. If there is no high risk feature, go for optimization and regular follow-up. If aortic dissection type B with high risk feature is present and there is development of complication, you measure the ascending aorta diameter. And if it is less than 45 millimeter and anatomy is suitable for TAVR, you go for TAVR within 3 months. If the ascending aorta diameter is not less than 45 millimeter, you go for frozen elephant trunk within 3 months. Now, if there is complicated aortic dissection type B, the features of complication I've already mentioned. The diameter of the ascending aorta is less than 45 millimeter and anatomy is suitable for TAVR. Go for emergency TAVR because complication has already been arrived. But if the diameter is not less than 45 millimeter and also the anatomy is not suitable for TAVR, you go for emergency surgery in the form of application of frozen elephant trunk. Now coming to the, after the surgical decision, coming to the anesthesia consideration, a thorough preoperative workup is required, the thorough investigation if the time permits, as well as the arrangement of the blood products. For any kind of aortic surgery, you will require a lot of blood products like the PRBC, the platelet, the gram precipitate. Some surgeons they also prefer the FFP also, and then you go for the surgery. So after proper preoperative workup optimization, you go for the surgery. Obviously, if the time permits. Now, the induction agent for the anesthesia, it is being chosen depending upon the physical finding of the patient, the age, the cardiac function, and the hemodynamic stability and hemodynamic effect of the agent you are choosing for the induction. If patient is hemodynamically stable, the cardiac function is within the optimum range, you can go for the inhalational agent induction, or you can even use the propofol also, or the high dose of narcotic. But if the patient is not hemodynamically stable, the cardiac function is very much poor, you go for the intermediate for the induction. But apart from this, apart from choosing the induction agent, at any point you have to control the pain component adequately, because any kind of pain will give the sympathetic surge, which is a very much risk factor for rupture of the aorta, even during intraoperative period also. So during the surgical procedure in the intraoperative period, whatever is the situation for pain, like sternotomy, like skin incision, like putting the invasive lines, these are all situations where there is sympathetic surge because of pain. You have to control the, you have to give the adequate analgesia prior to these events properly. The infusion in the form of adrenaline, noradrenaline, and nitroglycerin should be prepared before the induction itself, because during induction there could be surge of systemic pressure. You have to control it with nitroglycerin. There could be hypotension also. So the adrenaline and noradrenaline should be attached with the central line prior to the induction. The monitoring continuous cardiac output is desirable. TE, NIRS definitely is helpful if your arch has been involved, and the NIRS, I mean, SaO2 guided management. There is a flow chart in the Kaplan for management of management during intraoperative period according to the NIRS. You have to follow it if you are going for the hemi-arch or arch replacement surgery. Temperature management is of very much importance. Invasive blood pressure monitoring, preferably multiple sites should be monitored. The left radial as well as the femoral artery for measurement of the central pressure is desirable. The end organ protection, obviously, it is the joint venture of the perfusion team and the anesthesia team. There should be a thorough corroboration or communication between the surgeon, the anesthetist, as well as the perfusion team for the strategy of every end organ protection. Because for the aortic surgery, every end organ is at risk of ischemia during the intraoperative procedure. So for the perfusion, generally the antegrade arterial inflow cannulation is preferred. The femoral artery cannulation is generally to be avoided, to be on the safer side. You can use, but antegrade perfusion is always preferred. Axillary cannulation and antegrade perfusion is a type 1 recommendation. Multiple arterial pressure monitoring is again preferred. The left radial artery is preferred to know the perfusion pressure at which your brain is being perfused. And your femoral artery will give you, femoral artery pressure will give you the idea about the perfusion pressure for the rest of the body. The temperature monitoring, two sites are preferred. One is peripheral and one is core temperature. There should be matching between two temperature sites. When you are going for the hypothermic circulatory arrest, it is desirable to go the HCA under the core temperature guidance, that is the either rectal temperature, or the if you are measuring the core temperature invasively, it is also very much helpful. Now, the high moderate lower body hypothermic circulatory arrest in combination with selective antegrade cerebral perfusion for complex aortic arch or hemi-arch procedure is recommended, and it is type 1 recommendation. What is high, moderate, lower body temperature? I will discuss later. The selective anti-gate perfusion can be given either by axillary perfusion, axillary cannulation, or if your arch vessel has been involved directly, you can directly cannulate the cerebral arch vessels, the right carotid or the left carotid selectively. About the protection of the heart, retrograde cardioplegia is preferred because it's a long procedure, so you have to provide the cardioplegia repeatedly. So retrograde cardioplegia is preferred. If surgeon is not accustomed or not very much comfortable with retrograde cardioplegia, you can go with the Del Lido, which will give you a window period of around 1.5 hours. About the brain protection, I've already mentioned that NIRS-based algorithm approach intervention is preferred. In case of, if you have detected in the preoperative period through CT angiography that there is presence of incomplete circle of Willis, the patency is interrupted, then you have to go for trilateral anti-gate perfusion. That is, you have to cannulate the 3 major arch vessels separately. Although it is a ascending aorta replacement or the hemi-arch replacement, but sometimes we need this spinal cord protection. CSF drainage should be considered in total aortic arch replacement in patients at risk of spinal cord ischemia. It is class 1 recommendation. CSF drainage may be considered in type A aortic dissection patients with preoperative symptomatic spinal cord ischemia. It is class 2A recommendation. Now, what is the classification of hypothermia in aortic surgery? The deep hypothermia is considered when the temperature is less than or equals to 20 degrees Celsius. If the temperature is between 20.1 to 24 degrees Celsius, it is low moderate hypothermia. If the temperature is between 24.1 to 28 degrees Celsius, it is considered as high moderate hypothermia. And any temperature more than 28 degrees, it is mild hypothermia. So what about the post-operative management? We can apply the enhanced recovery after the aortic surgery if the patient is stable, very much stable in the post-operative period, and the repair surgery, the intraoperative event is very much uneventful, we can follow the enhanced recovery. At any cost, we have to maintain the normothermia because it's a long procedure, multiple blood transfusion, longer period, the chest is being opened. So normothermia to be maintained at any cost in the postoperative period. Femoral artery is to be considered as a preferred site for arterial pressure monitoring in the postoperative period because your radial artery could be at a it is in the spasmodic stage because of long procedure. Close monitoring of the lactate level in the post-operative period is desirable. You need not to send the lactate level to the lab. The newer generation of ABG machine, they give you the lactate level. And why it is important? Because it will give you an idea about the adequacy of your post-operative resuscitation. Because in the post-operative period, either the patient could develop low cardiac output or the patient could having in a hypovolemic state because there will be a lot of volume requirement in the post-operative period because third space loss is huge. So the serial monitoring of the lactate level is very much important. It will give you the idea whether your resuscitation in the post-operative period is going on the right way or not. If the lactate level is on the decreasing trend, you will be very much sure that your optimization is adequate. Regular laboratory coagulation parameter to be monitored, because coagulation derangement is a very common finding in the postoperative period. Why? Because of long pump run, because of hypothermia, multiple blood transfusion itself. These are the risk factors for coagulation derangement. So repeated coagulation parameter monitoring in the postoperative period is desired. Coming to the rehabilitation and surveillance once the surgery is over, in the long run, in patients after invasive treatment of aortic pathology, an individual cardiac rehabilitation program under medical supervision is recommended. This recommendation is individualized for individual patient itself. In patients after treatment for acute aortic dissection or intramural hematoma, irrespective of treatment modality, irrespective of type of surgery, CT angiography surveillance is recommended after 6 months and 12 months, and thereafter, in case of stable condition, annually for 5 years. This is the recent guidelines published in the year 2024 in European Journal of Cardiothoracic Surgery. It's a very good publication. Guidelines provided by EACTS and the STS in a joint platform. The guidelines are about diagnosis and treatment of acute and chronic syndromes of the aortic organ. Thank you. That's all.
Yeah, thank you, Dr. Soumitra, for elaborate discussion. It's a very huge topic to cover.
Yeah.
Nice. So I have two questions. First, how you manage pain in pre-operative area? Do you prefer morphine or fentanyl?
No,
Or
I give multimodal analgesia. I usually avoid diclofenac. The fentanyl infusion, the paracetamol, the buprenorphine patch, the tramadol. These are my first line treatment management strategy for pain control.
pain control.
But I usually avoid diclofenac.
Any NSAIDs because of already there are compromise.
Paracetamol is okay, but apart from paracetamol, I usually avoid, because although your initial creatinine level is low or within the normal range, but you are going to perform a major surgery, so there will be chances of AKI in the post-operative period. So
yes,
I usually avoid NSAID.
Okay, good. And what about Miss? How you counsel the patients? Suppose some patients have other organ dysfunctions. So accordingly, you have to counsel the risk factors, seeing the clinical parameters in patient profile. So it is a very high risk, or it is a moderate risk, or it's a usual risk. So depending on organ dysfunction or ischemia, so you have to counsel patient relatives also. Okay, how much? So generally, like somebody has gut ischemia, abdominal distension or abdominal pain is there. So naturally, the risk goes up. So generally, what parameters clinically you see?
According to the presentation, whether the end organ ischemia has started or not. If the end organ ischemia has started, it means it has entered into a very critical stage. The end organ involvement itself signifies that the patient has already entered into a very serious, very critical state. So whenever you are counseling the patient or the relative, you have to counsel in such a way that we are going for the surgery, and that is the only or the last resort for the management. But anything can happen in the postoperative period, because the aortic surgery is a very high risk surgery. And
Very high risk.
in a background of end organ ischemia, the risk increases in an exponential way.
Yes.
But if the end organ ischemia has not started yet, if such situation arises, again I used to counsel the relative that, see, we are going for the surgery, but any kind of complication can be happened in the postoperative period, like stroke, like paraplegia, like AKI, prolonged ventilation, deterioration of the cardiac function, like sepsis,
Yes.
like gut ischemia. So these are all potential complications even in the postoperative period. Even the patient is not having any end organ ischemia, but
Yes.
still they can be happened. And it
It
actually
can.
happens. It actually happens.
Yes, actually happens. Right. Okay. Do we have any questions from audience? I think nobody has posted. Dr.
Hello.
Monalisha.
Hello.
Yeah, Dr. Saikar.
Yes. Soumitra, nice presentation, elaborate presentation. I just mentioned 1 and 2 points. That point is that in various cases, aortic dissection, which is as you say that it may associated with Marfan syndrome or any other connective tissue disease. Okay. So other system involvement is very common. So we have to look also for the respiratory system and other connective tissue disorders that may happen, involve the coagulation system also. Patient may be associated with high arch palate. In that case, there is a chance of difficult intubation. Okay, and there may be a patient may be renal compromise due to any connective tissue disorder. So we have to look out also these things also.
True. Accepted. True.
Yes.
If the patient has presented, Shoykot said, if the patient has presented with aortic dissection in a background of any kind of syndrome, whether it is Turner syndrome, Noonan, or Marfan syndrome, if the time permits, if it is a chronic aortic dissection, we have enough time to work up properly about the syndrome itself. But if it is an acute aortic dissection, it is an emergency, so the time is very much constant. The routine investigation will do it, we'll go for the surgery, and after that we can follow up the patient with thorough investigation. Because every minute counts in case of
every minute is vital. But I say, suppose any reverse condition occurs, a case of laparotomy or any other abdominal pathology, abdominal CT shows an aortic aneurysm. Then what precaution we take?
I didn't get your question. Shukasar, could you please repeat it?
আমি বলছি ধরো একটা অ্যাবডোমিনাল কোনো এমার্জেন্সি, সাপোজ অ্যাকুট অ্যাপেন্ডিসেক্টমি or any other pathology, when we go for a CT scan, there may be an abdominal aneurysm. Okay, aortic
Incidental
aneurysm.
finding.
Incidental finding. Then in that cases, what we take precaution with during that emergency operation?
No, if the abdominal aortic aneurysm has been diagnosed incidentally, there are indications for abdominal aortic replacement. There are specific indications. Until and unless the indications are matching, the surgery is not recommended.
Okay.
Even if,
but suppose a patient has aortic aneurysm, goes for appendicectomy, then what extra precaution you take?
okay,
During appendix?
extra precaution is that the acute appendicitis is an acute situation. You have to go for the surgery. At the same time, you have to control the hemodynamics in a very fashioned way. I've already mentioned that your blood pressure should be systolic pressure should be between 100 to 120, and strict control of the heart rate also, because hypertension and tachycardia itself are risk factor for rupture of that aneurysm. Accordingly, you have to choose the anesthetic drugs.
Anesthetic drugs. Have you ever given
And at the same time, sir, at the same time, even if it is an abdominal surgery, I mean acute appendicitis, you have to prepare the adrenaline, noradrenaline, and nitroglycerin. You have to insert the invasive lines also. So proper invasive monitoring, as well as being prepared with the inotropes and the vasodilator should be ready in the theater.
Okay. Do you allow laparoscopic operation? Laparoscopic operation in aortic aneurysm?
Yes. Why not?
Okay.
Why not? Because definitely in laparoscopy, your surgical stress is less. Your postoperative pain will be lesser.
But any effect of increased abdominal pressure on the aneurysm?
If the actually for acute appendicitis, the abdominal pressure is kept on a very minimum range. I have to check the relation between the abdominal pressure because of laparoscopic surgery and the chances of rupture of abdominal aortic aneurysm. If there is any correlation is present or not, I have to check it, sir. I will let you know.
Suppose it is wrapped fully.
If I can add something here,
Yes.
I'm Dr. Shanko. If I can add something here, sir, abdominal aorta is a retroperitoneal organ, isn't it?
Yes.
Okay.
So if you are going for a pneumoperitoneum, and if you keep the pressures within 20 to 25 centimeter of or something like that, if you don't allow too high pressures, which you always obviously don't allow in a patient who doesn't have an aortic aneurysm also, so there shouldn't be a problem. And if it is a quick in and out, as Soumitra was telling, there shouldn't be a problem as such.
No,
and
but Sankoda, although your aorta is a retroperitoneal organ, but there will be transmission of pressure from the intra-abdominal compartment also. That I have to check. Frankly speaking, I didn't read it. I will check it and I will let you know, Shrikot sir. Definitely, I will let you know.
Yes, actually, when we work in case of cerebral aneurysm, we considered a factor about the transmural pressure. This is very important for neurosurgery. I have not so much experience in case of cardiovascular aneurysm surgery. For this, I asked this question.
Okay, no problem, sir. No problem. I will let you know.
Yes.
And Soumitra, why do we avoid paracetamol?
No,
he doesn't say. Paracetamol is not avoiding.
Sorry.
I avoid diclofenac or etoticoxib, any kind of NSAID apart from paracetamol.
Exactly.
One thing, Soumitra, can we measure the intra-abdominal pressure during that elective emergency appendix surgery? Intra-abdominal pressures can be monitored, I think.
No, for any kind of laparoscopic surgery, intra-abdominal pressure you have to monitor.
And it should be kept low in cases of dissections. And how much
if I can add here, Mona Lisa, something.
Yes.
You are asking how to monitor intra-abdominal pressure, isn't it?
Yes.
So that we don't develop an abdominal compartment syndrome, isn't it?
Yes.
So, and what Soumitra is telling, what I get from his expressions is that we measure how much of pressure we are, we are creating inside the from how much of pressure the gas is going through the, laparoscope. That we can measure. But if you want to measure intra-abdominal pressure, there is an indirect way to do that. What I found in one of my books when I was going for the EDIC exam, I found that if we if you have a urinary catheter and if we connect
Yeah,
it with
that
a
catheter. Yes,
transducer,
yes,
if we connect it with
yes.
a
The bladder
transducer, we
pressure.
would be able to, yes, the bladder pressure
Yes,
will
bladder
be an
pressure.
indirect reflection of the intra-abdominal pressure, isn't it?
Yeah. Yes, yes. That is the thing
Please
I
correct me if
was.
Yes.
I'm wrong. Please correct me if I'm wrong.
No, you are very right, brother. You are very
Thank
right.
you. Thank you.
So that is the thing.
So, so if we can keep a pressure, intra-abdominal pressure of less than 20, that is fine enough, I guess. Intra-abdominal pressure more than 20 to 25 can lead to a abdominal
Yeah.
compartment syndrome, isn't it?
Yes, yes.
But I'm not sure how much pressure it would create on an aneurysm, so that the aneurysm might burst, unless there is the aneurysm is almost what is the criteria for abdominal aortic aneurysm operative criteria? What is the criteria? 5.5 centimeter or something like that? What was the diameter criteria? I've forgotten actually. Is it 5.5
Yes, it
centimeter
is.
or
Yeah,
more
with
than 5.5?
bicuspid aortic valve, I think it is more than 4.5, and
Okay,
in
more than
general, it is
4.5.
5.5. More than
Is 5.5.
if
Yes,
it
yes,
is
yes. So,
associated with bicuspid aortic valve.
okay, 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 okay,
Otherwise,
okay.
5.5. In general, 5.5.
5.5. Thank you. Thank you so much.
Yes. So, I think Dr. Soumitra has disconnected. So please yes, Mona Lisa, you can close now.
Yes, I think Soumitra is there. He has just left because of the network issue.
Okay.
Okay. Sir, is Soumitra has joined again? No. So as we come to close the Heartlines episode 10, the acute aortic dissection and race against time, I think we all carry home our clear message that in condition, time is life. So we have seen how rapid diagnosis, immediate surgical coordination, and the vigilant anesthesia and critical care support can transform outcomes in what is often a catastrophic emergency. So it reminds us that beyond our skills and protocols, it is the teamwork and the preparedness that saves lives. On behalf of Heartline, I sincerely thank Dr. Soumitra for sharing for the excellent presentation and for sharing his vast knowledge and experiences. And I also thank all of you for joining, listening, and engaging in these vital discussions. Let us carry this learning forward towards our practice and be ever ready when the race against time begins. So, with that, we conclude today's
Sorry, I
session.
got
See you.
disconnected. I missed something.
Yeah, nothing. I'm just closing the things. I'm thanking you. It's a very good, excellent presentation. And on behalf of Artlines, I sincerely thank you for sharing the excellent presentation and sharing your vast knowledge and experiences on it. And let's carry forward this learning to our practice and be ever ready whenever the race against time begins. So with that, we conclude today's session. See you once again next week for another chapter of Heartlines, the low cardiac output syndrome, the voices of cardiac anesthesiologist. So stay inspired, stay tuned, and always listen to the heart. Thank you. Thank you very much.
Thank you.
Thank you.